Welcome to NCODA's Student Educational Talks. I'd like to thank you all for joining us this evening for March's Sets Conversations. I would now like to turn it over to Madison Motzner for some of our opening remarks.
Hello, my name is Madison Motzner, and I'm a third-year pharmacy student at Washington State University. I'm the current national president-elect of the NCODA PSOs, and I would like to begin with the PSO mission statement. Our focus is to offer an international community for healthcare students with a passion in oncology and pharmaceutical industry. We provide education, leadership, mentorship, and opportunities in research and community outreach. We promote unique and dynamic experiences for students to collaborate with all oncology stakeholders. I would like to welcome all of the established NCODA professional student organization chapters. We have South University, University of Rhode Island, Midwestern University, North Texas University, Washington State University, Texas Tech University, Purdue University, Nova Southeastern University, Massachusetts College of Pharmacy and Health Sciences University, University of Minnesota, University of Toledo, Albany College of Pharmacy and Health Sciences, University of Iowa, Lake Erie College of Osteopathic Medicine, Auburn University, University of Missouri, Kansas City, Binghamton University, University of New Mexico, Belmont University, Wingate School of Pharmacy, University of Florida College of Pharmacy, University of Utah College of Pharmacy, Howard University College of Pharmacy, Temple University, Shenandoah University, Oregon State University, University of Toronto, and finally, but not last, University of Colorado. I would like to welcome all of the in-progress NCODA professional student organization chapters as well. Thank you for continuing to help us expand. Welcome and all students listening in. NCODA will be providing student educational talks to all students regardless of membership. NCODA is growing by leaps and bounds. We are now 3,200 plus members and 600 plus practices strong. Working together, we become stronger. Stay up to date on all NCODA student events and resources by following the NCODA Professional Student Organization Facebook and Instagram page at facebook.com/NCODA Professional Student Organizations, or scan the QR code on the screen now. Also, don't forget to follow NCODA's LinkedIn page for all national updates. NCODA's Spring Forum is less than a month away. Registration for this 3-day virtual event is complimentary to all members. You can register and attend any sessions that you are able. We have 2 student tracks for the first time ever and will be featuring 3 keynote speakers. If you haven't registered, please do so today. Now, I would like to introduce our first speaker of the evening, Dr. Crystal Preston, who will be presenting on the program cell death pathway, an overview of PD-1 and PD-L1 targeted cancer immunotherapy. Go ahead, Crystal.
Good evening, everybody. I just want to first start off by saying that I certify that I have no conflicts of interest regarding this presentation. This presentation is solely for educational purposes and does not represent any employer or company associated with the author. Learning objectives. You all will be able to understand the program cell death pathway, understand the program cell death pathway's role in cancer, understand the role of anti-PD-1 and anti-PD-L1 monoclonal antibody therapies in cancer treatment. And lastly, you will be able to know the mechanism of action, indications, and important clinical pearls regarding current FDA-approved anti-PD-1 and anti-PD-L1 monoclonal antibody therapies. A little background. Our immune system plays an intricate yet necessary role in protecting us from disease and clearing out our own unhealthy cells that our bodies produce. Our T cells play a vital role in how our immune system works. The role of T cells includes selectively recognizing and killing various cells that are harmful to us, such as cancer cells. There are immune checkpoints within our immune system that ensure the cytotoxic T cells do not destroy our healthy cells, which we would then consider an autoimmune reaction. But cancer cells sometimes are able to evade this checkpoint system. However, in recent years, the use of monoclonal antibodies in blocking specific targets within this checkpoint system has played a key role in our immune system's ability to prevent the cancer cell's ability to resist the body's immune response. Next slide, please. The programmed cell death pathway. The programmed cell death 1 receptor, also known as the PD-1 receptor, and its ligands, such as the PD-L1 ligand, are categorized as immune checkpoint proteins that act as co-inhibitory factors that alter the T cell response. You will get a visual of this type of co-inhibitory interaction on the next slide, where the checkpoint system is able to control T cell proliferation, activation, cytokine production, alter metabolism, and limitation of cytotoxic T cell functions. This results in T cell immune suppression by controlling the T cell response magnitude and duration, which limits tissue damage and minimizes chronic immune inflammation. Again, cancer cells are able to intercede this pathway in order to evade the body's proper immune response. Next slide, please. Here we have pictured is the tumor microenvironment. So basically what's going on in this picture is that under normal conditions, the immune system performs a stepwise approach that involves T cell release of cytotoxins. These cytotoxins induce apoptosis in the targeted cancer cells. Cancer cells have the potential to mount an immune resistance mechanism to this response due to the overexpression of the PD-L1 ligand, and it inhibits the programmed cell death pathways mediated anti-tumor activity. PD-L1 on the tumor cell binds to the PD-1 receptor on our T cells, resulting in its deactivation. With the cytotoxic T cells being deactivated, this allows the cancer cells to continue to proliferate, therefore escaping this anti-cancer immune response and cancer cell death in this microenvironment. Next slide, please. So this picture shows a more focused approach of the role of PD-1 and PD-L1. So as we briefly discussed earlier, the PD-1 receptor is expressed on activated T cells. It is also expressed on B cells, macrophages, regulatory T cells, and natural killer cells, which all help to recognize the foreign cells such as tumors. These tumor cells are able to evade our normal T cell mediated immune response due to the release of interferon gamma, which is showed at the bottom of the picture, and that leads to the overexpression of PD-L1, which allows them to subsequently bind to the PD-1 receptor on the T cell. Next slide, please. Mechanism of action. It is important to note that the mechanisms of action of these two groups of monoclonal antibodies therapies are revolutionary in the fact that they do not target tumor cells themselves, but rather they target our own immune system's T cells so that they can detect, bind to, and kill the tumor cells. PD-1 inhibitors bind to the PD-1 receptors on T cells and prevent the ligands PD-L1 on tumor cells from binding, whereas the PD-L1 inhibitors bind to the PD-L1 ligands themselves in order to block the interaction with the PD-1 receptor. Both mechanisms reverse T cell suppression and induce the anti-tumor responses that were described earlier. Thus, the tumor cells are no longer able to evade the normal T cell mediated immune response. Next slide, please. Now we will discuss the anti-PD-1 monoclonal antibody therapies, Keytruda and Opdivo. Next slide, please. Keytruda. It was initially approved in September 2014 for melanoma. It has since acquired more than 20 FDA approvals. The indications that I have listed on this slide are the ones that I most commonly see in my practice. I have even seen it being used for triple negative breast cancer for an off-label use, of course. Dosing. A typical dose is 200 milligrams IV every 3 weeks. However, since then, there has been a 400 milligram IV every 6 weeks dose approved for certain indications. And of course, we want to monitor our patient's renal function and hepatic function and other dose limiting toxicities that may result in either withholding or permanently discontinuing Keytruda. Next are the most common adverse effects. These include metabolic disturbances, which are most commonly seen with hyperglycemia, hyponatremia, hypocalcemia, hypophosphatemia, hyperkalemia. Next, we'll have hematological effects, which include anemia and thrombocytopenia. We'll have decreased hepatic function, decreased renal function, which is normally an increase in serum creatinine, but not truly reflective of a patient's renal function. Then we'll have musculoskeletal pain, so different arthralgias and things like that. We'll have GI disturbances, which include nausea, vomiting, diarrhea, and constipation. Increased infection risk, fatigue, and pruritus. Next slide, please. Next, we have Opdivo. It was initially approved in December of 2014 for melanoma. It has similar indications as Keytruda. The indications listed are again the ones that I most commonly see in my practice. Typical dosing is 240 milligrams IV every 2 weeks or 480 milligrams IV every 4 weeks. There are also some indications that are that require weight-based dosing. And I wanted to point out that Opdivo is often used in combination with another immune checkpoint receptor inhibitor called Yervoy, which blocks the CTLA4 receptor on T cells in the indications of melanoma, colorectal cancer, and renal cell carcinoma. I also wanted to point out that Opdivo is the first and only FDA-approved PD-1 inhibitor to offer every 4-week dosing. So in my practice, we normally see every 2 weeks or every 4-week dosing, and it's based on patient preference and or clinical status, as some patients may need to be monitored more closely in the fact that they need to come in to get labs and be seen by the doctor. So that may make a big difference in when a patient is going to get treated. Again, these side effects are similar to what we've seen with Keytruda. However, with Opdivo, I wanted to point out that for metabolic disturbances, Opdivo causes an increased thyroid stimulating hormone levels, leading to hypothyroidism. And also it causes increased triglycerides in addition to all the others that I named before. So this is why it is important to monitor patients' lab work. In addition to all of those disturbances, we have a lot of electrolyte disturbances that I previously mentioned. And sometimes at my practice, we'll add IV hydration orders, and we'll add in whatever electrolytes in which they are deficient. Next slide, please. Now we will discuss the anti-PD-L1 monoclonal antibody therapies, which are Tecentriq, Imfinzi, and Bavencio. Tecentriq. Initially, it was approved in May 2016 for urothelial carcinoma, also known as bladder cancer. It's used mostly in metastatic and advanced cancers. It is dosed every 2, 3, or 4 weeks based on indication. Most patients in my practice are on the 1200 milligrams IV every 3 weeks regimen. Again, we have similar adverse effects as we have seen with all the others I have previously discussed. Next slide, please. Next, we have Bavencio. Initially, it was approved in March 2017 for Merkel cell carcinoma, which is another form of skin cancer, and it is quite aggressive, but it's also very rare. Again, this drug is also used in advanced and/or metastatic disease. Typical dosing is 800 milligrams IV every 2 weeks. Per the manufacturer's suggestions, patients must be pre-medicated with an antihistamine, such as Benadryl, and we need to add on Tylenol for the first 4 infusions. These pre-medications may be discontinued for subsequent infusions based on the physician's clinical judgment. We currently have a bladder patient on this drug at my practice who has a history of infusion-related reactions. So our team has decided to continue these pre-meds with each infusion. And again, the most common side effects are listed, similar to the previous drugs. Last but not least, we will discuss Imfinzi. It was initially approved in May 2017 for advanced bladder cancer. However, as of February of this year, AstraZeneca announced the voluntary withdrawal of Imfinzi in the United States for the indication of previously treated adult patients with locally advanced or metastatic bladder cancer. It comes from an initially granted accelerated approval based on promising tumor response rate and duration data in their phase 2 clinical trials, based on the assumption that the phase 3 trials would meet similar endpoints, which evaluated the safety and efficacy of Imfinzi in advanced, previously treated bladder cancer. However, in the 2020 trials, it was determined that it did not meet these endpoints. Typical dosing is 10 milligrams per kilogram every 2 weeks. However, in November of 2020, the FDA approved an additional dosing option, which is 1,500 milligrams fixed dose every 4 weeks in approved indications of unresectable stage 3 non-small cell lung cancer after chemoradiation therapy. And this is the alternative to the 10 milligrams per kilogram IV every 2 weeks. In small cell lung cancer, the dosing is for patients weighing less than 30 kilograms, 20 milligrams per kilogram every 3 weeks or every 4 weeks. And then for patients weighing greater than 30 kilograms, it is 1,500 milligrams every 3 weeks or every 4 weeks. And we have the most common side effects that we've seen in the other drugs as well. Next slide, please. So to wrap up, there have been many breakthroughs in the way we treat cancer, many of which are attributed to the immune checkpoint system, specifically using the programmed cell death pathway. Immunotherapy alone or in combination with chemotherapy provides patients additional treatment options with the potential to cure certain cancers. As healthcare providers, It is our responsibility to continually educate ourselves and be advocates for patients to improve outcomes in their treatment. Lastly, it is important to monitor patients, such as their hepatic function, kidney function, and complete blood count, as very toxic effects can occur as a result of taking these drugs. And that is it for me. Here are my references. If you have any questions, I'm open to hearing them, or I can put my information in the chat and you guys can email me.
Thank you so much, Crystal. We appreciate your presentation. If anybody has any questions, feel free to reach out to Crystal. It looks like she just put in her email for anybody. So if anything comes up, feel free to reach out to her or myself, and I would happily pass on anything that comes up. Our next presenter is Caitlin Kelly, a pharmacy PGY2 resident at the University of Chicago Medicine.
Hi, everyone, and thank you, Austin. My name is Caitlin again. I am almost done with my second year of pharmacy residency at the University of Chicago, and today we will be talking about hypercalcemia of malignancy. So for our objectives, my goal for you to take away from this presentation is to be able to describe the pathophysiology of hypercalcemia of malignancy, be able to identify the presenting signs and symptoms, and then also be able to recommend a treatment plan for a patient with hypercalcemia. So just starting off with the background. So hypercalcemia of malignancy is pretty common for a metabolic abnormality, which can be seen both as an inpatient as well as in the ambulatory setting. Reported in patients is about 20 to 30%. Most commonly, it's seen in our multiple myeloma patients, especially when they're just presenting with multiple myeloma. For the prognosis, it's pretty poor if it's left untreated. It's actually 50% of mortality within 30 days, and then 6.8% of hospital mortality. There are multiple different types of hypercalcemia. I'm really just focusing on the two more common ones. The first one is the local osteolytic hypercalcemia. This is seen in about 20% of the patients presenting. Most commonly, this is going to be due to our bone metastases. The causal agent is usually the chemokines and osteoclast activity, which we'll talk about in the pathophysiology. This is typically seen, like I was talking about with that multiple myeloma group, as well as other solid tumors like breast cancer. The other common one with about 80% frequency is going to be the humoral hypercalcemia. And this one is actually going to present in a different way. It's not really going to have the bone metastasis feature, but the agents are going to be due to the parathyroid hormone related protein, or the PTHRP, which really acts similarly to the parathyroid and actually will bind to the same receptor of the parathyroid. So this is also seen in multiple different types of tumors. So it could be squamous cell, renal cell, carcinoma, ovarian, endometrial, as well as breast cancer again too. So starting with the pathophysiology, like I was saying, they present in two different ways. So if we start at the top of this, where you see the cells in the primary tumor, these are the ones that are actually activating that PTHRP gene. So this is elevated. And like I was saying, it binds to the parathyroid receptor, which then triggers the bone to increase bone resorption. So it increases those osteoclasts to then break down the bone. And then this releases calcium into the bloodstream. The other way that you can look at this too is where you have bone metastases in the bone already, and you'll see the PTHRP is going to actually be minimal or a normal level if you do look into this. But the bone actually will produce the PTHRP, which then also causes bone resorption in the bone and then breaks it down and then releases the calcium into the blood. So then if we look at the next slide, we can kind of keep in mind how the patient's going to be presenting, and what we're looking for is kind of similar to someone who has hyperparathyroidism, in a sense. So when the calcium is excreted, the body tries to think that it needs to keep this calcium. So then this will cause renal insufficiency because, one, you have a lot of calcium in your blood. So it can actually cause obstructions in the kidney, causing renal damage, as well as it's kicking in to either, it's kind of causing calcium reabsorption, as well as in the intestines too. It's going to try and absorb a little bit more of the calcium as well, because everything's kind of not in the same balance. So it's imbalanced within the body. So when we look at how our patients are going to be presenting on the next slide, it can range from very non-specific symptoms to pretty severe. So, and this is how we're going to determine this with the severity. So for the neurological symptoms, it can be from fatigue all the way to altered mental status, confusion, and into coma. For the more severe cases, GI symptoms is also a very common side effect. We'll see nausea, vomiting, as well as constipation. Because you have a lot of calcium in your blood, depending on how much you do, the patient can actually have calcium deposits that can cause arrhythmias and hypertension. And there also can be seen renal dysfunction. So with the renal insufficiency, that can be due to any damage, but then also your kidneys are trying and get rid of the calcium too. Overall, if this is left untreated, it can become pretty severe and cause tubular atrophy, as well as interstitial fibrosis too. So for the assessment, so you as the pharmacist that's on the clinical team, you should be looking for the serum calcium, the vitamin D, as well as albumin. So why do you think that we're looking for albumin with our calcium? If anyone would like to answer.
The corrected calcium.
Right, exactly. So so there's about 40 to 45% of the calcium is actually protein bound to our albumin, which then we need to figure out how much calcium is actually in the patient's, what is their actual level. We'll also be looking for the parathyroid hormone, as well as monitoring that serum, or the serum creatinine for the renal dysfunction, looking to see what other medications that patient may be taking, if maybe they take a lot of Tums, or there's another type of medication that's also increasing their calcium too, and then a bone scan to see if they have any bone metastases. So to figure out the severity, like I was saying, so with the calcium attached to the albumin, we want to go and calculate our corrected calcium equation. So this is, remember, the serum calcium plus 0.8 in parentheses with using the normal albumin of 4 minus the actual patient's albumin. So with this, we can then base this off of the severity of mild, moderate, and severe. I like to think that about 12 and under is your mild, 12 to about 14 is your moderate range, and then above 14 is where you get the more severe, is the severe category. So keeping this in consideration and going to our next slide, I would like you guys to just test it out as a refresher. So we have a 65-year-old male, or female, sorry, who's admitted for confusion and lethargy. She has a history of multiple myeloma, and her calcium's 10.1, her albumin is 2.9. What would be her corrected calcium? And if need be, I don't want to call on somebody if someone would like to volunteer for the answer, but I can call on somebody too. How about either Jason? Do you have an answer? Or Shantae? Oh, that's okay, Jason. Sorry. So that's okay. So using the corrected calcium, it comes out to be 10.98 using that equation. Perfect, Jonathan. Awesome. So then if it's 10.98, what would be the severity?
Would it be mild?
Perfect. Yeah. So hers would technically be mild. You can see she's having more mild symptoms with the confusion and lethargy. But then you would just have to figure out what the full picture is. But for her, she's more in that mild range. So awesome, guys. Thanks. So we always like to keep in consideration, one, what's their calcium, but also how is that patient presenting? And this will help determine our treatment later on. If they have mild, well, one, we have to see, are they asymptomatic or are they symptomatic? Then the next step is the mild to moderate patients will probably just have those more mild non-specific symptoms. But when the patient has more rapid or severe symptoms, like significant volume depletion, acute renal insufficiency, as well as neurocognitive symptoms like altered mental status, this is where we can keep this into consideration for adding on another type of treatment. So what we can think about is with our mild, moderate, and severe. So mild, like I was saying, so it's really those non-specific symptoms, and their calcium is on the elevated side, but the main thing they're going to really need is hydration. Moderate is where we can add on a treatment with a bisphosphonate. Typically, it's with zoledronic acid. And then severe is where you have to consider if we should add calcitonin on top of the zoledronic acid and the hydration. Typically with our institution, we really don't add on calcitonin unless they are having pretty severe neuro symptoms, or if they have any cardiotoxic symptoms, like if there is something that's on their EKG, or if they're like if they're experiencing an arrhythmia. So then going into the other managements, starting with hydration. So one, the first thing you need to remember is to use normal saline. You shouldn't be using lactated ringers. What would be the reason why we don't use lactated ringers? And think about what's in lactated ringers. So calcium is also in lactated ringers, which is typically why we want to avoid it. And normal saline is our go-to for hydration. So pretty much we give hydration to correct that intravascular volume depletion to pretty much help dilute the calcium within the body. For the dose, it can range between 2 to 4 liters per day, or about 200 to 500 milliliters per hour. Overall, though, we want to be looking at the urine output of the patient and have them above 100 milliliters per hour. For the onset, it's pretty fast. Typically, it could be minutes to hours compared to the other treatments. Main side effect, which makes sense if we're giving them fluid, we don't want them to have too much fluid and be hypervolemic. And like seen in the previous slide, we are giving this for all of our patients that we're treating hypercalcemia, so mild to severe. Our next step is going to be our bisphosphonates, and this is the mild to moderate region that we'll be adding this on. So we are giving bisphosphonates to inhibit that bone resorption and stopping the osteoclast formation as well too. So we just are pretty much stopping the breaking down of the bones. Main adverse effects, we have to keep in mind, the main two we have to keep in mind would be nephrotoxicity as well as hypocalcemia, which is what we want to decrease the calcium. The other side effects, we just have to monitor for if they do continue on with treatment, but if with a one-time dose, their risk is a lot lower. The main difference though with this indication compared to any other indication you'll use bisphosphonates for is you are not going to adjust the dose for renal insufficiency. So it's still going to be the same dose. So our two different treatments, most commonly it's going to be the zoledronic acid, but you can also use pamididrate too. For zoledronic acid, it's 4 milligrams over 15 minutes times 1. And then if the patient is not responding, you are able to repeat another dose in 7 days. Both of these onsets are going to be between 24 to 72 hours. So something to keep in mind too, when the patient's admitted and your team is asking you why the calcium isn't lowering as quickly as they thought it would, because it takes a little bit of time for it to kick in. The duration though is longer, which is why we have to wait the 7 days, because it's about 2 to 4 weeks. And similar between the two. For denosumab or Xgeva, this is another option that you can use, typically more in the refractory setting though. This is the monoclonal antibody that blocks the rankle to rank to prevent osteoclast formation, so working in a different way. This one is a subcutaneous form of 120 milligrams given on days 1, 8, and 15 for the first month and then monthly. Onset is similar to the bisphosphonates, about 24 to 72 hours, and then similar duration as well too, of up to a month. Also has similar side effects of fatigue, edema, headache, as well as nausea, vomiting, and diarrhea. But again, main role would really be you're going to this if this patient's refractory. Typically, you're not going to be using this in a first-line setting. Your next step would be the more severe cases, so the calcitonin. So this works in a different method as way too. A different method as well. This inhibits your bone resorption as well as increases your renal calcium excretion. So typically this is also released from your thyroid as well too. So it can also work in your kidneys to help with the resorption as well too. The dose is between 4 to 8 units per kg intramuscularly or subcutaneously every 12 hours. Onset's pretty fast. So it's about 2 to 6 minutes, but it only lasts for 48 hours. The main thing you have to think about for calcitonin is a tachyphylaxis, and it can occur within 48 hours. And then because it downregulates the receptors for it. So you really have to keep in mind of when you're going to give this to the patient and if the patient really needs it. So like I was saying, this is really only for your neuro or your cardiac symptom patients. Main toxicities on top of the tachyphylaxis we have to keep in mind is if they do have a hypersensitivity to salmon products, if you do know that at the time, as well as it can cause myalgia and nausea. And then again, this is the more moderate to severe with those symptoms. Supportive care measures, these can be started between mild all the way up to severe patients. So with giving a lot of that fluid for the hydration, loop diuretics are kind of going to be your go-to to make sure we're also excreting the fluid too. This also promotes urinary calcium excretion too. Your dose, it's going to vary between the patients, but typically you'll start with about 20 to 40 milligrams IV a day, and then adjust the dose based on how the patient's responding. We're going to also give phosphate supplementation too. When you do have high calcium, typically your body excretes a lot of the phosphate. So typically your phosphate is going to be pretty low. So we got to supplement that to bring it back. And then you can also use steroids as well. This can help enhance your calcitonin effects because it upregulates your calcitonin receptors for new osteoclasts. Typically for the dose, it can be about 60 milligrams of prednisone or equivalent for 10 days. But this one is more just to keep in the back as an option for later on. It's not typically used within the initial therapy. So overall, for hypercalcemia and malignancy, we have multiple different ways that we can treat this. So main go-to is going to be your hydration, your bisphosphonate, and then possibly adding on your calcitonin. And these are my references. And do you guys have any questions about hypercalcemia? If not, you guys can email me too. I'll put it in the chat again. It was on the beginning of the slide, but I'll put it in there too. And you guys are welcome to email me too.
Thank you so much, Caitlin. We appreciate your time this evening and hearing you give your presentation. Next, I would like to turn it over to our next presenter, Erica Ianatuono, a Senior Medical Science Liaison from Genentech.
Thank you, Austin. And sure, I want to thank you all for having me. I was asked to give a little bit of a foundation on acute myeloid leukemia today, so I'll be sharing my slides in just a second. But I guess before diving in, I just want to give a little bit of background on myself. It's always a pleasure to be amongst students. I'm a pharmacist myself. I actually kind of took the residency route after graduating. I'm a MCPHS alum. And ended up specializing in oncology. So I went to Mass General, then Memorial Sloan Kettering to specialize in oncology for residency, and then was actually a professor at St. John's and got to teach my APPE students about acute leukemia every day on service at New York Pres Cornell. So this is very near and dear to my heart, and it's always wonderful to have the opportunity to talk with students. So I'm going to share my screen. Let's see if I'm allowed to. Here we go. Alrighty, can you all see that? I'll put it into presentation mode. So just keeping with everyone, just a quick disclaimer, this will all be FDA approved and on label. There won't be anything off label, but there will be a brief reference to other non-Genentech products as we're talking about the landscape, just to give a quick disclaimer.
Erica, it is, we do see it in presenter mode currently. So we see like—
Oh, you see mine?
Yep.
Yeah, let me swap displays. Is that better?
Yes, it is. Thank you.
Okay, thank you for that. This way it's a little bit easier to see. The most important picture is a little bit small on this slide. But when we talk about acute myeloid leukemia, also known as AML, I think it's important just to break down the three components of the title, right? So acute, it comes on rather quickly. Some other leukemias can be, of a more chronic nature that come on a little bit more slowly. So this disease comes on quite quickly. It affects the myeloid line. So you can see this picture will go in a little bit deeper in just a second. So this is where the cancer actually occurs, and it's leukemia, so a cancer of the blood. And so, as mentioned by the acute in its title, it's a very aggressive, it's a fast-growing cancer. And what ends up happening when you think of, how your blood cells are made, in particular those of the myeloid line, they start at the stem cell and then end up differentiating into the different components of the myeloid line. So either it differentiates into a red blood cell, either platelets or your granulocytes. And an easy way to remember if a cell is a granulocyte is it ends in phil. So basophil, eosinophil, and neutrophils there. And so what ends up happening is these myeloid blasts, depending on what the true etiology is, either it gets locked in this phase and ends up over-replicating, these blasts end up over-replicating, or there's a mutation that leads to over-replication. But essentially, there's an overproliferation of these myeloid blasts. They typically end up crowding out your bone marrow, which leads to different cytopenias when the patients present, and then also can have high white blood cells since there's this overproduction, right? And the myeloblasts should really only be seen in the bone marrow, which is, your blood cell factory in your body, and typically should not be seen in the periphery. So it's only a very short time where the myeloid blasts are, present in a normal person's blood cells before they end up differentiating into other cells. So that's, where the cancer truly is when we talk about AML. And AML, it's not a very common cancer in the grand scheme of cancers. It actually only comprises 1.1% of all cancer. And with that, only less than 20,000 people were diagnosed in the United States in 2020. It commonly affects older patients. The median age of diagnosis is 68 years old. And presently it's believed that about 51,000 patients have AML in the United States. So unfortunately, AML typically confers a poor overall survival, or when you think of diseases in 5 year overall survival, it's about 29%. And it's better, if you're a younger patient, they tend to have better 5 year survival, about 45%. But if those patients are greater than 65 years old, it's only about 6.7%. And this is talking from a historical perspective. Now, when we think about, how do we approach treatment? Usually it's whether or not the patient's a candidate for more intensive treatment. So about 2/3 of patients are candidates for more of a high intensity treatment that we'll discuss in a second. And if they're not, they'd be candidates for more of a low intensity regimen. And historically, it's either has been a hypomethylating agent, so azacitidine or decitabine, or low dose cytarabine. And depending on the studies you look at, the median overall survival ranges from about 5 to 10 months. So lots of room to improve, outcomes in these particular patients. When we think about how these patients present, it's, you think, all right, so you're not producing the correct blood cells that you need, right? So you have low red blood cells so you have anemia that confers, patients will present with fatigue, weakness, shortness of breath. They could have bruising or bleeding because of the thrombocytopenia or low platelets, or they can be prone to infections because they have low neutrophils or neutropenia. Very rarely, you can see, those leukemic cells going places outside of the peripheral blood or the bone marrow, and they can infiltrate your gums. So commonly, well, not commonly, but dentists have made diagnoses or told the patients, go see a doctor, seeing inflammation of the gums on a dental exam. And you can also have infiltration into soft tissues, and that could be called a leukemia cutis or a chloroma, actually. Patients may have inflamed lymph nodes or a large spleen. That's less common for AML. But if a patient's a very proliferative disease, you can have what they call leukostasis, or settling of the white blood cells in the vasculature, almost like a white clot. Since these AML blasts are actually large, sticky cells and like to accumulate sometimes when there's too many of them. And almost, the opposite of the previous talk, you can't see tumor lysis. And so essentially when these cells break open, whether due to chemo or just automatically, you can have those intercellular contents spilled out into the blood. And so you can have high potassium, high uric acid, you end up having high phosphorus, and then that would bind the calcium, leading to low calcium. And you can, with that, have high LDH, since there's a lot of cell turnover. This disease, it's diagnosed by, it can be in the peripheral blood. Either they have 20% blasts or more in the peripheral blood, or bone marrow biopsy. Most patients are given a bone marrow biopsy, though, to confirm diagnosis. And if the patients were to have any of these particular cytogenetic aberrations, translocation 821, inversion 16, or translocation 1517, that last one's also known as APL, acute promyelocytic leukemia, they'd be diagnosed with AML without having to meet that 20% threshold. So the doctor and medical team will do a complete blood count, get the differentials to see what the makeup of that CBC is. The bone marrow, they'll end up immunophenotyping the cells. So this is typically done by flow cytometry, just to look at the markers outside the cell to confirm the diagnosis of AML. And we'll also run genetic analyses, so looking at cytogenetics and molecular mutations. And this is how they can tailor treatment, whether it be in the frontline setting or maybe in the relapse refractory setting. As you'll see, there have been a lot of new drugs that have come out the past 3 years in this setting. Since AML is so rare, we don't exactly know the cause But there are some risk factors associated with the development of acute myeloid leukemia. Like I said, most commonly seen in older patients. It's more likely to be seen in men than women, and in white patients, it's more common. So non-Hispanic Caucasians have a higher risk of AML. Um, there are some genetic syndromes. So Down syndrome is actually a risk factor for AML, and Fanconi anemia. And if patients have antecedent myelodysplasia, so myelodysplastic syndrome is what MDS stands for, sometimes called a pre-leukemia, they have a higher risk for transformation into AML. And if the patient has myelofibrosis or other myeloproliferative neoplasms like essential thrombocythemia or polycythemia vera, they would have a higher risk for AML too. If the patients were previously exposed to either benzene, formaldehyde, cigarette smoke, radiation, and cytotoxic chemotherapy. So patients, may commonly you can see patients who had breast cancer before and now, maybe about, depending, it could be like 5 to 10 years later, developing acute myeloid leukemia, for example, because of that chemotherapy exposure, which is why patients end up, get consented to receive chemotherapy for their first diagnosis. So it's not, every patient is different, right? And we should always take an individualized approach to treating these patients. It's not necessarily just young or old, right? There are other factors that should be taken into account. So there are your individual patient factors. So that does include age, their ability to go on to receive transplant, since transplant is truly the only curative option for these patients. And typically, in addition to comorbidities, there can be an age cutoff, roughly used about 74 years old, but obviously performance matters too. Patient fitness, so their performance status, functional status, comorbidities, and the like also should be considered when thinking about treatment options, as well as disease-specific factors. So cytogenetics, and if you were to look in the NCCN guidelines, there are risk categorization for different cytogenetics and can tailor treatment, as well as molecular abnormalities, which you'll see in the chart later, that it could guide therapeutic intervention, whether in the frontline or maybe in the relapse refractory setting as well. So in the beginning, I mentioned intensive chemo versus low intensive chemo, and so when intensive chemo is discussed, it's really been the same approach for the last 30 years or so, actually maybe even a little bit longer. This intensive chemotherapy, it's typically given to younger patients. And it's called intensive because it ends up leading to a long duration where the patients are neutropenic. They have a high risk for febrile neutropenia and the like, and really need some reserve to be able to receive this chemo and make it through safely. And so the backbone of the intensive treatment is going to be cytarabine. It's usually, you'll hear it referred to as 7+3. There are other regimens, but the very basis of it, it typically includes cytarabine as well as daunorubicin or idarubicin and anthracycline, right? So you probably have learned in school that you need good cardiac function to receive an anthracycline. So it's one thing to keep in mind. And you can see that, this typically is associated with higher rates of complete response and confers a longer overall survival. And typically, patients would go into receive a transplant following their induction chemotherapy. For those patients who can't tolerate a treatment such as that, they would historically have received a low intensity regimen. So either a hypomethylation agent, monotherapy, decitabine or azacitidine, or low-dose cytarabine. And you can see the much lower rates of complete response, much shorter overall survival. We're talking a matter of months in this situation. And actually it takes quite a while to respond to treatment, about 3 to 4 cycles before the patients would really be checked to see if they were responding. So a lot of unmet need in this area. And thankfully in the past 3 years or so, so I left clinical practice in mid 2017, and this is just on the horizon. Nothing had been approved yet. So right since I have left, there's been 6 new oral agents in AML, which is really exciting, and a lot of other therapies as well, a few more injectables. So it's always great to see a chart like this in the NCCN guidelines, because prior it was just that previous slide, just one of those 3 monotherapies for these patients. But with that, for as a pharmacist, right, you have to keep on top of it, learning these new agents and kind of where they fit. So a great guideline is the NCCN guideline. You may be familiar with it, National Comprehensive Cancer Network, and they try to give some guidance, right, as far as treatment selection. And we have now gotten to the point in acute myeloid leukemia that they're looking to try to stratify it based on targetable mutations and the like. So one of the agents, venetoclax, it was approved in November 2018 for acute myeloid leukemia in the frontline setting for patients ineligible to receive intensive chemotherapy, is a very common agent used and is now made category 1 status. So you can see this drug associated with a ramp up, just a 3-day ramp up, and the patients would take 400 milligrams daily, and that's in combination with a hypomethylating agent, so azacitidine or decitabine, and less commonly used with low-dose cytarabine, but could be. But there are also other agents for targetable mutations such as IDH1 and 2. So ivosidenib, that does carry an FDA indication in the frontline. Enasidenib does not yet, but you can see it is listed in the NCCN guidelines. And then for FLT3 mutations, the data isn't there just yet with the targetable agents, but there are 2 other FLT3 targeted FLT3 inhibitors. One, midostaurin, is used in the more intensive chemotherapy setting in combination with 7+3, and then there's another agent, gilteritinib, that's used in the relapse refractory setting. So there are lots of new drugs, and 6 of them oral. When you think about NCODA scope, lots of new oral agents in the leukemia setting. So I know we're really close to time. I just wanted to give you a little taste and kind of build a foundation, since I can tell you when I was in pharmacy school, I got all leukemias in about a half-hour section and ended up learning it a lot later in residency. So wanted to, kind of have the opportunity to talk a little bit deeper about the more highly spoken about leukemia, as there are so many new agents recently. And it's possible, you may see them on your boards potentially. So wanted to thank you all for your time. If anyone has any questions too, please don't hesitate. I'll stop sharing here too. Just leave a couple minutes. Here, I'll leave my. There you go.
Thank you to all our presenters tonight. We appreciate it. Hopefully our students were able to learn something. I know definitely leukemia is one of the main ones that you don't cover much. So hopefully this was at least, if not an introduction, another good recap for everybody. So again, we appreciate all of our presenters for joining us this evening. We also appreciate all of our students for taking time out to learn a little more about oncology. And I wanted to let everybody know our next student educational talk will be April 28th, again at 8 p.m.